Yeah, dear organizers, thank you very much for having me. Ladies and gentlemen, I'm very happy to be here. And yeah, so it's now with this presentation, it's getting less scientific. It's more or less a potpourri of cases that we treated in our lab. And I think as a result of this, we can provide you with some tricks if you encounter similar situations. And I'm sure that many of you have encountered similar situations or have even more complex cases that could be presented. So if we are looking at the agenda, we're staying in line with Dr. Gupta, with my previous speaker, because most of the complications or most of the problems that I encountered during LAA implantation has to do with access. Either venous access or transeptal access and LAA access. So we need to enter three different spaces. And I have three examples here where it can get difficult. Then I want to talk or spend a couple of slides on comorbidities. So different approaches in special situations. Of course, what can we do about device recapture? And let's spend one slide on side effects of the therapy. Okay, so this slide highlights or underscores the value of using echocardiography when you perform the transeptal puncture site. This is a very special situation. A patient who had previously undergone an interventional occlusion of an atrial septal defect, and as you can see from the TOE image right here, this 30mm occluder leaves very little space for your transeptal sheath in order to access the left atrium and further on the left atrial appendage to occlude it. And the very first try of me and my colleague was to puncture at the site where we usually puncture. However, the ASD occluder was there, and because we know from literature that sometimes you can go through the struts of the occluder and dilate it, we were absolutely unable to pass a regular transeptal sheath into the left atrium, although we were using a lot of force, and then changed our strategy. And again, this really highlights then, or I think this is very difficult to be done without echo guidance. And we managed to puncture the septum very posterior and very inferior to the occluder. And as you can see from the X-ray image, that's the corresponding image, the puncture site. And ultimately, we were successful in placing an LA occlusion device in this patient. So what is the message? Message number one is that if you have the referral for LA occlusion in a patient who had previously undergone interventional PFO or ASD occlusion, you should not deny, and you should say, okay, it's feasible, but if you do so, you should certainly use ICE or TOE to guide your transeptal puncture. Little earlier in the story of the procedure is the venous access. And as I said, most of my problems that I have during the procedures is to bring this sheath up. Because a lot of our patients have tortuous venous anatomies with kinking, and the double curved sheath sometimes is very difficult to manipulate through these curves and then to get it across the septum. So one possibility in this scenario is to use a very stiff guide wire, like an Amplatzer extra stiff or ultra stiff, in order to straighten the anatomy and to give you more support to bring up the sheath. However, I still prefer, if I have such an anatomy, not to bring a regular transeptal sheath up and do the transeptal puncture, and 5 minutes later, take the transeptal sheath out and bring the double kink torque view sheath up. Because it's two exchanges, and 2 times I have to pass the kinking, and we just heard about retroperitoneal hematoma, which can easily occur when you apply too much force to these kinked veins. Therefore, we developed an exit strategy for these scenarios, and we prefer to use a steerable sheath, a custom-made steerable sheath to guide number one, the transeptal puncture, as you can see here in a case for a fib ablation. In most of the times we're using the cryoballoon sheath, which is a 12 French inner diameter sheath, steerable as you can see from the image, and you can use this with an 89 centimeter Brockenbrough needle, BRK1 needle from Abbott, and you can, as you can see here, perform transeptal puncture easily. And using this sheath, it has a 12 French inner diameter, as I said. You can at least implant devices up to 25 millimeter, as you can see from the next video. So it's the same patient, same, it's a different patient, but same sheath. And as you can see here, we were able to implant the device with this steerable sheath. I have to admit that it is a little bit difficult to get the device through the hemostatic valve because the cryo sheath has a strong hemostatic valve, but this should, I don't know if R&D people are here from Abbott, this should kindle your interest in developing a similar sheath for difficult cases in LA occlusion. So next axis would be left atrial appendage. Sometimes, depending on your puncture site, depending on the individual anatomy, very enlarged left atria, or in this special situation, a partially ligated left atrial appendage, it can be difficult to enter the left atrial appendage in order to place your device. And for me, in these small openings here, it is virtually impossible to place a pigtail catheter in the left atrial appendage. That's why we prefer to use a ball-shaped lobe to enter it, or, and this is the trick of the electrophysiologist as shown in this example, if the opening is even smaller, you can see from the panel B that we were able to enter the left atrial appendage using an electrophysiology catheter. In this case, it is just a decarpolar straight tip catheter, but it gives you support, and it's steerable, of course, so sometimes it can be really helpful to enter the left atrial appendage instead of using a pigtail or a ball-shaped amulet device. Of course, you could argue now this is a tip catheter. A lot of force can be applied to the thin-walled left atrial appendage. That's why I'm a little afraid of using it. And in for these cases, I prefer, or I can recommend to use a lasso-shaped catheter, as you can see from these two panels. This is what we usually use in left atrial fibrillation ablation patients to enter the left atrial appendage to have a stable reference. So this is if you go to your EP colleagues and ask them about a lasso catheter, this can be a very neat aid to enter the left atrial appendage atraumatically. A second reason why I'm showing these two images is that recently there's an extensive discussion in the EP world that electrical isolation of the left atrial appendage might confer to better outcomes in patients who have ongoing AF despite chronic pulmonary vein isolation. And this is an example of one of our cases. On the left-hand side, before the ablation, on the right-hand side, after a Cox maze-like procedure with linear compartmentalization of the left atrium, resulting in electrical LAA isolation. And as I'm sure you see the difference in contraction between the two scenarios. And I hope you would agree that this patient should also undergo LAA occlusion in the long run for his acontractile left atrial appendage. Let's continue with patients with comorbidities. I think as we saw this morning, many of our patients have various comorbidities, and sometimes this puzzles us to apply a large load of contrast media in order to avoid pulmonary edema. Some of them are allergic to contrast media. Hyperthyroidism plays a role, and of course, contrast media-induced nephropathy may occur. That's why we developed a strategy to exclusively guide the procedure with echocardiography. In our lab, we're using TOE. And as you can see, this can be nicely done using the Amulet device. On the left-hand side, you see the still image of the present anatomy. On the right-hand side, another angle to this. This is, of course, the prerequisite. You have to have a very good view of the anatomy in order to appropriately choose the device. But if you have a good echocardiographer who can do it, you can then continue, guide your transeptal puncture, left upper, then you advance the ball-shaped lobe into the left atrial appendage, and on the left lower, you can see that the device is placed, the disc is developed, and on the right-hand side, this is the final result. Using color Doppler, you see there's no residual flow, and the procedure can be performed without using any contrast media. What are our experiences with this? This is not a single case. Until today, we have performed 11 cases, so it's a small case series, of course. And as you can see, out of 432 implants that are in our database, that makes equals 2.5%. I have to admit that I became a little more liberal in doing this after I gained confidence that this is a safe and an effective approach. So I guess one could choose even more patients for a contrast-free approach. See a relatively young patient population in comparison to the registries, less than 70 years of age, but high risk. And as you can see from the bar graphs, success rate was 100%, and the need for repositioning the device was needed in 9 out of 11 patients. So it's most of the times a really first deployment approach. Of course, I have to admit, in an experienced center. How long does this take? Does this prolong procedure times? No. Mean procedure time 29 plus minus 10 minutes, and fluoro time 1.9 minutes. So I think very, very straightforward. Now, another problem that we might face is the following: a so-called malignant left atrial appendage. I think this term comes from Thorsten Lewalter. At least he's the one that I heard it from the first time. So this is a gentleman who has had atrial fibrillation, and despite being treated with vitamin K antagonists and various NOACs, he still had a thrombus in the left atrial appendage, and he also had thromboembolic events, actually. And after another treatment period with dabigatran for 6 or 8 weeks, he presented again with this left atrial appendage, and half of it, at least half of it, was filled with dense material suggestive of thrombus. And maybe now we could just ask one question. You see the results of what we did, but what would you do in this situation? Would you send this patient to surgery to cut out the left atrial appendage and the thrombus? This would be answer A. Would you B, perform a left atrial occlusion, or C, would you continue drug treatment? Will you be able to do this in a... The question, yeah, we need a short time. So surgery, LA occlusion, or drug therapy. Does it work? Okay, yeah, interesting. So 10% or roughly 12% would send the patient to surgery, 1/3 would go for occlusion, and then half of you would continue drugs. However, I think it's a good option. However, in this gentleman, most of the NOACs had already been used. So we were really desperate and decided to go for a B. So we decided to put a device on top of the thrombus. And I think this is, of course, a contraindicated situation according to the IFU of the Amulet. But we considered this a bailout strategy. And what I find, or what is important if you would ever consider in doing this, is that you do not perform LAA angiography using a pigtail catheter because you could easily dissolve the thrombus and cause thromboembolism. So we just used an ultrasound-guided entrance or navigation to the LAA with the partially opened occluder and then put it on top of the thrombus, and you see the result here. Patient was discharged uneventful. So bailout LAA occlusion in a malignant LAA. Now, very briefly, what do we do in Bonnie situations when we have embolized devices? This was a lady who came for 6 weeks after implant of an ACP, it's a couple of years ago, and was very happy that she might not need any antithrombotic treatment anymore. And then we performed the controlled TE 6 weeks after the procedure, patient completely asymptomatic, and you see that the device completely embolized. What did we do? We considered in retrieving this device transeptally. You can see a transeptal puncture has been performed already, and then of course, you need a bigger sheath. This was a 30-millimeter device. We decided at that time to use a mitra clip sheath, and we snared the device with a large gooseneck snare. You can see this on the left panel. Centered the device and trapped it at the interatrial septum. And then using a second snare, we caught one of the screws and pulled it back into the sheath and completely retrieved it. So we have performed another case like this using the cryo sheath, but you need a large bore sheath in order to retrieve these devices. So again, EP is important. Lastly, very briefly, side effects. The most terrible side effect of LA occlusion is pericardial tamponade. We know it's getting less and less. It's only 0.5% in the AMULET registry, but still it's there. And if you encounter it, be prepared. And this image is therefore very important. That's the first thing when I ever proctor cases in outside hospitals. I ask the people, do you have everything for pericardial access if you encounter tamponade? Because in the emergency situation, you will never be able to find everything you need, and it just delays treatment. So just make a picture of this. You need a needle, you need a sheath, you need a pigtail catheter, maybe some contrast media if you like to do this, and a long wire. And then you're well prepared. Thank you very much for your attention.